Progress.
Hi. So I recently gave a talk for my company about status epilepticus, and I thought these would be some good slides just to share with you guys. So we'll talk a little bit about what status epilepticus is, how you diagnose it, and how you treat it as well. This is coming more from a clinical standpoint. As a patient, I think this is a really good time to discuss seizure first aid. Oftentimes, patients aren't aware of what exactly seizure first aid is. If you have any questions on it, epilepsy.com has a very, very good course where they go through it with you. You can actually get seizure first aid certified. And I think that's very important because, a lot of us are ACLS, BLS certified in case of cardiac emergencies, but I think being seizure first aid certified is just as important because let's remember, 1 in 26 people in the world are going to have a seizure at some point, and there are a lot of people out there with epilepsy. So, even if it's not someone you know or a loved one who's having a seizure, even if it's a stranger, when you're taking a walk in the park, I think it's helpful to know seizure first aid so you can get that person help. So I figured this would be a good time to plug this. Seizure first aid, again, you can get seizure first aid certified with the Epilepsy Foundation. The information is on the epilepsy.com website. But just briefly, this is what you do if someone's having a seizure. You stay with them until they're awake or alert until after the seizure, and you have to remain calm yourself. They have a medical ID, that's always helpful. It's also helpful to note what time the seizure is happening because when EMS gets there, they might ask for how long the seizure lasted for. Number 2 is to keep them safe. So all of these steps are going to start with an S, which is going to be helpful. So number 1 is stay, number 2 is safe, them safe. Keep them away from harm if they're in the middle of traffic, if a crowd is surrounding them, just try to guide them to an area where it's safe. Then you lay them on their side. The reason that is important is if they start spitting up or vomiting or frothing, that they're not choking on those things. So you want to turn someone to the side. You want to keep the airway clear. Please do not put anything in anyone's mouth during the seizure. You're not going to bite your tongue off. In fact, you might actually choke on the thing that someone's trying to put in your mouth. And keep that airway, clear in a sense that not just don't put anything in someone's mouth, but also loose and tight clothing like a tie or anything that they might strangle themselves on. If available, you can put something small and soft under the head, but of course, I know that's not going to be readily available for everyone. But those are just some of the tips. Of course, there's never a wrong reason to call 911. But if a seizure lasts longer than 5 minutes, or if the patient is pregnant, if this is their first seizure of life, or if the patient does not return to their usual state of awareness, I think that's a great time to call 911. If they're having difficulty breathing, if they're turning blue, if the seizure is occurring while they're in the water, and also very importantly, if they're having back-to-back seizures without return to themselves in the middle, that could suggest status epilepticus. So definitely call 911. And of course, don't restrain someone. Do not put anything in their mouth as we described. If this is someone you know and they have rescue medications and a seizure action plan, I think it's totally okay to administer those medications. Again, register for training at epilepsy.com/first aid. I think this is really helpful. Right. Let's talk a little bit about status epilepticus now. So status epilepticus is a medical emergency. You can have prolonged or repetitive seizures. Prolonged seizures, meaning seizures lasting than 3 minutes. Used to be a half hour and then it became 5 minutes. I now count it at 3 minutes. Any long seizure or repetitive seizures where you're having a cluster of events back to back and the person's not returning to baseline, that is always concerning for a status epilepticus condition. This is dangerous because the longer someone is in a seizure, it can require medical attention. It can be life-threatening because now you're depriving oxygen to the brain and time is brain. Of course, if you are in a seizure for a long period of time and you're cutting off that circulation and perfusion to your brain, you can end up with a certain amount of anoxic brain injury that is not reversible. Remember, your brain cells do not regenerate. So that's part of the reason status epilepticus is dangerous. Another reason it's dangerous is because when you're having a seizure, it takes a lot of toll on the other systems on your body, most notably your heart and your lungs. That is kind of the pathophysiology under SUDEP too. So we want to make sure that these seizures don't last for a long period of time. There are many reasons someone can be in status epilepticus. The most common reason is, of course, someone with epilepsy, where they do have recurrent seizures, but for some reason they're having now clusters of seizures or prolonged seizures. This is the most common reason. However, you can also see status epilepticus in patients who are having other conditions like acute brain injury. If you've had traumatic brain injury and you've never had a seizure before, that can trigger a long seizure, and that still counts as status epilepticus. Metabolic disturbances. You can be someone without epilepsy and still have seizures, right? If your blood sugar is really low, if your sodium and your calcium are affected, that can also lead to status epilepticus. Medication withdrawals, and that's just not stopping anti-seizure medications quickly, but also something like benzodiazepine. If you're on a long-term opioid or a benzo and you're cold turkey stopping it, that can lead to a seizure. Infections can lead to a seizure, especially like meningitis or encephalitis, that can lead to seizures. And then, of course, toxins, drugs, alcohol, amphetamines, all of those things that can disrupt the way the brain functions can lead to status epilepticus. Usually someone who presents in status epilepticus has prolonged seizures. They don't always have to be generalized tonic-clonic. Those are just the easiest ones to spot. They can be subclinical, which is why if someone is done having a seizure and they're not clinically moving around anymore, but they're still not back to themselves, we always ask for an EEG, because subclinical seizures are just as dangerous as clinical seizures, okay? Now, subclinical seizures are ongoing seizure activity via the electricity in your brain. So when you put an EEG on someone's head, their brain is still having a seizure. They're just not clinically making any movements, which in some ways is more dangerous because you're unable to tell that this person is having a seizure. At least if you're clinically having a seizure, you know, people will notice it and give you help right away, but subclinical seizures are equally dangerous as well, and they're not uncommon. Usually the treatment is as follows: benzodiazepine. So if you're someone at home, you're with someone who has seizures and they have the nasal sprays, the Valtocos, the diazepams, or even the diastap rectal inserts, go ahead and give that to them. If that's not available, what EMS, when they arrive, will do is give them a benzodiazepine, such as lorazepam, diazepam, or midazolam. Now, diazepam and midazolam can come in the nasal spray forms, which is why it's important to ask about rescue medications. But without them being available, or if this is someone who doesn't have a seizure history, benzodiazepines will be what EMS gives you. If you're still having a seizure despite that, they'll give an IV medication. If someone's already on one of these, then they can just give you a little bit extra. But if this is someone who is not on any of these medications or has never had seizures before, the second line medications we know that work that we use are lacosamide, which is Vimpat, levetiracetam, which is Keppra, fosphenytoin, which is Dilantin, or valproic acid, which is Depakote. These work further to suppress abnormal brain activity. If despite second line medications, you're still having seizures, now you're in a zone called refractory status epilepticus, which can be very dangerous. These people require generalized anesthesia like propofol or Versed drips to just quiet the brain. At that point, an EEG should also be applied to make sure that someone is not having subclinical status epilepticus. Once the seizures are treated and the EEG does not look like ongoing seizures, then you can start the workup about why this happened. Of course, you know, you can also do that while someone is having their seizures, but I think stabilizing the patient is of utmost importance. Once you identify and start treating the underlying cause, hopefully you can start pulling back on some of that anesthesia and lightening the sedation to wake the person back up. To do all of this usually requires an ICU admission and monitoring, because a lot of these medications can not only affect the brain function, but also vital signs, your cardiac system, your liver, can also lead to potential complications. I just wanted to give this algorithm out. So if anyone is having status epilepticus, you have to first maintain ABCs, and that's where seizure first aid comes in. You come in, you make sure that the person is laying on their side, you stay with them the whole time, making sure their airway and breathing is okay, and circulation, of course, call 911 if needed. Never a wrong time to call it, especially if this is someone you don't know. If they have rescue medications, I think you can do that. Otherwise, EMS will do the lorazepam and midazolam. By the way, if you've done rescue medications, there's no real contraindication for EMS to also do them as long as the airway is being protected. Person is still having seizures, then we load them on either Keppra, Dilantin, Depakote, or Keppra, Dilantin, Depakote, or phenytoin. Phenytoin is actually the same thing as fosphenytoin. It's just a better formulation of it. So that's on their device. I'm sorry. What is missing on that slide is lacosamide, which is Vimpat, which has been readily introduced in the last 5 to 10 years, which is probably why it's missing. They're still having seizures, and you can go on to propofol or midazolam, which is Versed, and try to sedate the person. If they're still having seizures, then you can move on to a pentobarbital coma. You see at the bottom, it says ketamine ? That is something that is a neuroanesthetic that has also recently been starting to be used, and that's helpful. And then the other medication that we also use sometimes is phenobarbital. Someone is continuing to have seizures, that's also another medication we can try. It's used very commonly in children. But you can use it in adults as well. You can use that before progressing to the propofol or the Versed. It really depends on a case by case basis. And that's about it. That is how you treat status epilepticus from a clinical standpoint. Now I'll do another series on just regular seizures that are not status epilepticus, what causes those and how to treat those as well. But for right now, I hope this was helpful. I decided to just do it because, like I said, I recently gave this talk and I think it was helpful for a lot of us clinicians and also non-clinicians. Thank you so much for joining, and let me know if there's anything in the future you want to hear about. Thank you.